Hello, my name is Jennifer Stransko, and I'm the Physician Engagement Associate for MAVEN Project. Thank you all for joining us today and our friends at Puyallup Tribal Health Authority for hosting today's session, ECG Mini-Series #1, Basics in Heart Block with Dr. Charles Schulman. Dr. Schulman is a senior physician emeritus who recently retired from active practice after 53 years, but continues to teach and consulting. In addition, he has been practicing non-invasive cardiology since 1970. Dr. Schulman's scientific articles and abstracts have appeared in the New England Journal of Medicine, Circulation, the American Journal of Cardiology, and the British Heart Journal. His research interests include the treatment of hypertension, congestive heart failure, and hyperlipidemia. And with that, Dr. Schulman, it's all yours.
Thank you very much, Jennifer. And hello, everybody. Welcome to our webinar. This is the first of 3 ECG talks that I have reviewing the topic of electrocardiography. The title I've given it is the A to Z of EKGs, or AFib to zebra. We're not going to talk about atrial fibrillation today, but we are going to talk about some of the basics of electrocardiography and in addition to heart block. I have no disclosures, and the session is designated for 1 hour of Category 1 credit. The learning objectives are that you should be able to understand the anatomy and blood supply of the cardiac conduction system, understand the formation of the clinical ECG and axis in the frontal plane, and recognize normal rhythm, bundle branch block, and heart block. Here's a picture of Dr. Einthoven, who invented the electrocardiogram in 1902. Here's a picture of a fellow who, using one of the first ECG machines. Incidentally, EKG is German and ECG is English. You notice that he has his hands in 2 buckets of saline and doesn't look very happy. We've come a long way, as you can see. Here's another one of the early EKG machines. And this fellow also has his hands and 1 foot in buckets of saline. So in the last 120 years, we've gone from this to this, where you can record an ECG on a smartwatch, print the data, and then subject it to AI analysis, and get an estimate of left ventricular pump strength. So a lot of information there that we don't ordinarily see. Now, to start with the anatomy of the cardiac conduction system. So the SA node is located in the upper portion of the right atrium at the junction of the superior vena cava. The impulses travel from there across the atria on specialized bundles called Bachmann's bundle to the AV node. There's a slight pause there. Then the impulse travels to what's called the common bundle or the His bundle, and then to the bundle branches, and then to the His-Purkinje system and the myocardium. The blood supply for these structures is as follows. The SA node is fed in 60% of people from the right coronary, 40% from the left circumflex. The AV node is fed in 90% of people from the right coronary, 10% from the circumflex. The right bundle and the left anterior fascicle of the left bundle are fed by the left anterior descending coronary artery. and the posterior fascicle gets a mixed supply. One basic tenet of electrocardiography and electrical recording is that when an electrical vector travels from a reference electrode to what are called an exploring electrode, in our case, that would be the ECG leads, recording an ECG. When it travels toward the electrode, it will produce a positive deflection. When it travels away from the electrode, it will produce a negative deflection. And we'll talk more about the direction of these vectors as we go. Temporally, what happens is that the SA node does not cause a deviation in the baseline of the electrocardiogram. But as the impulse travels through the atrium, you get a deviation called the P wave. When it reaches the AV node, we're back to baseline, and then the His-Purkinje system is the QRS. So small q, large R, small s. And then the ST segment and T waves are recovery. The limb leads 1, 2, 3, AVR, AVL, AVF, those leads are called the limb leads, and they form what's called Einthoven's triangle. So lead 1 is negative. These are bipolar leads. Negative in the right arm, positive in the left arm. Lead 2, negative in the right arm, positive in the foot. Lead 3, negative in the left arm, and the left arm, positive in the foot. The other foot is the ground. And the AVL, AVR, AVL, AVF are what are called unipolar leads. So the reference electrode is sort of in the center of the body. Toward the foot is AVF, toward the left arm is AVL, toward the right arm is AVR. So here's a gentleman, here's an ECG that the computer read as showing atrial flutter with 4-to-1 AV block. Is that true? Somebody want to put an answer in the chat? Yes or no? No, no takers. Okay, well, it looks like it's flutterish, except over here in lead 3, which is some normal sinus rhythm. Okay, so you can't have flutter over here and sinus rhythm over here. These are simultaneous. And so the problem is that this fellow has a tremor. He has a Parkinsonian tremor. Okay, and so the question is, which arm has the tremor, right or left or both? And we can use Einthoven's triangle to try to figure that out. So lead 1 has a tremor. So that means that either the right arm or the left arm has it, or both. Lead 2 has the tremor. So that means the right arm and the left leg. Lead 3 doesn't have it. Okay, so that means that the left arm is the one without the tremor, and the leg doesn't have the tremor either. So that which one has the tremor? The right arm. Now, those were the chest leads. These are excuse me. Those were the limb leads. These are the chest leads. V1, 2, 3, 4, 5, 6. Notice V1 is located on the right side of the sternum. The others are all located on the left side of the sternum. When you go from lead V1 to V6, there's something called R wave progression. Okay, so the R waves, here's a little one, here's a little bigger, here's a lot bigger, you know, and they grow until about V5 is usually where the highest, but it's sometimes a V6. Depolarization of the ventricle starts from left to right, therefore you have a little R wave, and then a large vector to the left, giving you an S wave. Whereas in these leads over here, there may be a tiny Q wave followed by a large R wave. Okay, this shows the calculation of axis, and on a 360-degree scale, I use 2 leads in order to figure out axis. Make it easy. Lead 1, which is the horizontal, and lead AVF, which is the vertical. And once you know, look in those 2 leads, you can figure out where the axis is, whether it's normal, whether it's right, whether it's left, or whether it's called various things: extreme axis deviation, no man's land, or northwest axis. That's a picture of the Seattle Space Needle, which I think is a lot closer to you folks than I am. For describing the findings on an electrocardiogram, we recommend a systemic approach. So you want to consider the heart rate, the heart rhythm, the intervals, PR, QRS, QT, the axis, whether or not there's chamber enlargement, and whether or not there is ischemia, infarction, or bundle branch block, QRST changes. So here's normal sinus rhythm. You have a P wave followed by QRS followed by T. The rhythm is perfectly regular. There's a P wave in front of every QRS. Okay, the normals for PR interval are 120 to 200 milliseconds. QRS 80 to 120 milliseconds, and QT interval less than 470 milliseconds in men, 480 in women. So you can also calculate heart rate, or very quickly calculate. Really, it's kind of an estimate, considering that the standard paper speed is 25 millimeters a second, so that each small box is 40 milliseconds and each large box is 200 milliseconds. So you can calculate rate this way. Mark some portion of the QRS, okay, here right at the beginning of the R wave. And then if the next beat is here, their heart rate is 300, 150, 100, 75, 60, 50, 43. Here is a normal ECG. The QRS, narrow complex, the the QRS, and the QT durations are all well within normal limits. The axis would be positive in 1, positive in AVF, which would put it in the normal range, and ST segments and T waves all look quite normal. There's another one. Now, in this one, there are kind of prominent Q waves in the inferior leads here. Okay, and also a little bit laterally. And people wonder whether those are normal Q waves, or really what they're concerned about is if they're abnormal and represent some previous infarction. The answer comes by looking at the Q wave. So a non-pathologic Q wave will be narrow and short. Pathologic Q wave will be wide and perhaps 25% of the R wave amplitude. So that this is a pathologic Q wave. This is not. Okay, so here we have another electrocardiogram. What is the axis? Okay, normal, left, or right? Somebody want to put an answer in the chat? Is it normal, left, or right axis?
Someone said left.
Left axis deviation. Correct. Okay, then lead one, it's positive, which makes it to this side of the horizontal of the vertical, and negative in lead AVF makes it up here, this side of the horizontal. So it's left axis deviation. Here's another one. What's the axis here? Well, it's negative in one, which puts it over here somewhere, and positive in AVF puts it down here, meaning there's right axis deviation. Now, ventricular hypertrophy produces increased voltage. That's the characteristic of ventricular hypertrophy. And the criteria, the simplified criteria for diagnosing left ventricular hypertrophy is tall T, or is a lot of voltage, deep S waves in V1, 2, 3, and tall R waves in V5, 6, which is what this ECG shows. So add them together, and they should total 35, particularly if the patient is over 35 years old. Left ventricular strain are these STT changes that are secondary changes due to the LVH. Here's RVH, okay, right ventricular hypertrophy, with a lot of voltage traveling toward the right. These appearances often are in congenital heart disease when they appear in lead V1. You don't usually see anything quite that striking. As a matter of fact, here's a patient with COPD, and you don't see that large R wave. But what you do see is that R and S R is greater than S in V1. So that's very suggestive of RVH in a patient with COPD, and tall peaked P wave in lead 2, called P pulmonale, indicates right atrial abnormality. So that goes along with the right RVH in this patient with emphysema. Okay, so here is a 47-year-old asymptomatic man who had an acute inferior MI 5 years ago. Okay, and here's his ECG. He's got sinus rhythm, narrow complexes. The measurements are all within normal limits, but look at the axis. It's down in 1 and isoelectric in F. So that makes it almost directly 180 degrees. This is a very strange axis. What's going on here? Are there really Q waves in one in AVL? Did he have an old anterior infarction or lateral infarction? Sometime that we didn't know about? Or what we should do in a circumstance like this is try to find a previous tracing, or try to find a. As a matter of fact, that's generally a good idea when you're trying to determine whether STT abnormalities are new or old, and rhythm is new or old. See if you can't find a previous ECG. But when we looked at this man's baseline, we found, before the baseline, excuse me, you'll notice that R wave progression is normal. So what do you think's going on? What's going on is this is artifact, and the electrodes for the left arm and the right arm are reversed. So whereas the left AVL is supposed to look like this and AVR is supposed to look like that, in fact, it looks just the opposite because the arm leads are misplaced, and lead one is upside down. So we can go back and look at it. You see, so in fact, this is upside down. This is really AVL. This is really AVR. See? So this is artifactual and a result of reversed arm leads. So if you see that, I hope you'll be able to recognize it, and don't do anything very drastic except repeat the ECG with the electrodes properly applied. Now, on Christmas Eve, if you hear hoofbeats on the roof, what is it more likely to be? Santa Claus's reindeer or a zebra? Don't bother putting anything in the chat because it's pretty obvious what the answer is. We often refer to zebras as rare events. Although I'm told that you can't say that in South Africa because there are so many zebras. So here's another patient, 66-year-old man who presented with a 3-day history of cough, congestion, and pain in his chest. And look at his axis. The axis, it's just the same as the previous patient, right? Way negative in 1 and isoelectric in F, making it 180 degrees. So are these reversed arm leads? Or does he have something, something weird about the location of his heart? Well, look at the R wave progression here. As you travel further and further to the left, you see less and less voltage, as if you were traveling away from the heart. And a chest X-ray gives the diagnosis. There you go. It's got what's called dextrocardia, or situs inversus. His heart is located in the right side of his chest, not the left side of his chest. His lungs, incidentally, his lungs are clear. Okay. Now, turning to bundle branch block, we review the bundle branch anatomy. So here's the AV node, here's the common bundle or His bundle, here's the right bundle, here's the left bundle, which divides into an anterior fascicle and a posterior fascicle. And conduction in right bundle branch block, so we're now talk about right bundle branch block. Normally, the impulse goes from the sinus node to the AV node to both ventricles at the same time. But with a blocked right bundle, it goes from sinus node to the AV node to the left ventricle, and then secondarily comes back to the right. If you look at V1, here's the initial septal depolarization. Vector heads toward the left, right? Toward the left. And then secondarily comes back to the right. So this is called RSR prime. And this is typical right bundle branch block appearance. In V6, which is located out laterally, almost the axilla, this S wave is the equivalent of the R wave in V1. Here's left bundle branch block. Again, septal depolarization goes from left to right, and then all of the vectors travel to the left. So you may or may not get a small R wave, but you get a deep fractured S wave in V1, and in V6, you get a fractured R wave. So here we go. Sinus rhythm with bundle branch block. Which one, left or right? Put your answer in the chat. The answer is right. This is right bundle branch block. You know, the sort of the quick and easy to remember this is that, remember, V1 is located on the right side of the chest. So right bundle branch block will go toward V1, that is up, and left bundle branch block will go away from V1, that is down. So if the wave is up, it's right, it's down, it's left. Okay, here's another one. Bundle branch block, wide QRS complex. Which bundle is this one? Left. Correct. This is left bundle branch block. Okay. Now here's an asymptomatic 36-year-old man with a wide complex, but it's a funny looking one, isn't it? The PR interval is very short, and the QRS, the beginning of the QRS has a slurred upstroke. See? This was described in 1930 by doctors Wolf, Parkinson, and White, and is called WPW, Wolf-Parkinson-White syndrome. What it is pre-excitation. So there's a bypass tract that goes, there's transmission not through the AV node, but bypass tract either on the left or the right, causing this delta wave. There are doctors Wolf, Parkinson, and White right there. Okay, now turning to heart block. Okay, we start with the heart block poem. If the R is far from P, then you have a first degree. Longer, longer, longer drop, then you have a Wenke block. If some P's don't get through, then you have a Mobitz 2. If P's and Q's don't agree, then you have a third degree. So that's one of my favorite poems, although that's not winning any awards for poetry. So first degree AV block, which we really prefer to call AV delay rather than actual block. The PR interval is prolonged, see, greater than 200 milliseconds. So here's this one's prolonged, and this one's prolonged even further. So that's first degree AV block or first degree AV delay. Here's second degree AV block. Some beats are conducted and some are not conducted. One of these patients needs a pacemaker. Which one? Do you know? Okay, someone says two. I take it that's B. And that is the answer. That is the answer. Here, you'll see that the PR interval is this, then it's longer, and then there's a drop beat. So this is Wenckebach conduction. Whereas this, all the PR intervals are exactly the same until there are drop beats. So this is what's called Movitz 2. This is classic Wenckebach conduction, or Movitz 1. Movitz came along a few years after Wenckebach, and noted that what we now call Movitz 2 had a different origin than what we now call Movitz 1 or Wenckebach. So here's a typical Wenckebach cycle. PR is 210, 380, 540, drop beat. One of the characteristics of Wenckebach conduction is that after the pause, the PR interval shortens compared to before the pause. Okay, so Wenckebach, or Movitz 1, takes place in the AV node, so it's a matter of relative refractoriness. Here's Movitz 2. Beats are either conducted or not conducted. PR intervals are all exactly the same. This is basically an all or nothing phenomenon. And Movitz 2 takes place in the His-Purkinje system. So that's why people who have Movitz 2 need a pacemaker. I'll show you an example of what can go wrong in a couple of slides. One way of trying to differentiate type 1 from type 2 block is to have the patient exercise. So here's a patient of mine who was 69 at the time, complained of exertional chest pressure, so he had a stress test. And here's his rhythm. This PR interval, longer PR interval, drop beat. So he has Wenckebach Movitz 1 conduction. He had this all the time. It didn't bother him. When he exercised on the treadmill, conduction improved. You see, right? Here's one-to-one conduction. So, and then afterward, it went back to where it was before. So, Movitz 2 reacts in the opposite way. So, having a patient exercise a little should improve conduction. Whereas this is what can happen with Movitz type 2, which is why we put pacemakers in these folks. Here are PR intervals all the same until there's no conduction that goes on and on and on, and then resumes. 6 minutes later. Is that right? 15:22. No. Well, okay. And when it resumes, PR intervals are again all the same. You see? So, this is third degree AV block, also called complete AV block. The arrows mark off the P waves, and you see that the P waves have no relationship to the QRSs. The ventricular rate is much slower than the atrial rate. And so this is complete heart block. Here's another example of the same thing. The P waves kind of march through. Here, say, there it comes out afterward. Okay, so, I mean, this looks like it might be conducted. It might be, but probably not, because the R intervals are all exactly the same. So this is a junctional rhythm and complete heart block. Now, here's an elderly woman who presented with syncope and then complained of chest discomfort. And she has a slow rhythm. Her ventricular rate is 47. Is this a sinus rhythm? Look at the P waves. There's one in there, one there, one there. There's probably one buried in here, here. Okay. So the atrial rate is actually a tachycardia. 300, 150. It's a sinus tachycardia. A little less than 150 beats per minute in the atrium, and the ventricle is going at 47 beats per minute, and the P waves have no relationship to the QRSs. So this is third degree AV block. Why? Because, and we'll talk about this when we talk about ST and T wave changes, but there are ST elevations in leads 2, 3, and AVF, consistent with an ST elevation acute MI. And what's that got to do with heart block? The right coronary artery feeds the AV node in 90% of people, so that heart block is from AV nodal ischemia. And it's generally resolves on its own, and no pacemaker is generally needed. So in that case, we can point to this fellow. The doctor says it's a pacemaker for your heart, plus you can download apps for your liver, kidneys, lungs, and pancreas. Thank you very much. I'll be glad to entertain any questions that you have. You can put them in the chat or raise your hand and we'll unmute you. And I review the 35 rule? Sure. We can go back to that. Oh, well. Oh, there it is. No, there it is. Okay, so the 35 rule is you take the deepest S wave in V1 or V2. So here's 5, 10, 15, 20, 25. And the tallest R wave in V5 or V6. So 25 plus 25, 30, 35, 40, 45. So that makes the diagnosis of left ventricular hypertrophy. Okay? Yeah. Can you count on the machine uh, to measure intervals? Yes, 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 yes. The computers are very good at that. So I generally accept what they say. And uh, uh, the question is, would I recommend a routine ECG during physical exams if patients are over a certain age, even if asymptomatic? Um, uh, uh, you have to understand I'm a cardiologist. So of course, anybody that comes to see me is going to get an electrocardiogram. But um, I think it's useful to have at least one during a lifetime for reference purposes. So even if it's normal, certainly you don't have to do it every time somebody comes in for an annual physical. That's that's too much. That's not necessary. But if you do one over the age of 50, perhaps, I would say over the age of 50, I might do one at some point, uh, just to, as I say, as a reference point. Okay, for patients with newly diagnosed hypertension without a baseline EKG, can the EKG be done in PCP office, or should it get done and read by a cardiologist? No, I think you can read it. You can do it. And the chances are that the chances are the machine reading will be correct. Although I have a whole collection of ones that are not correct. But then again, I'm looking for those. Um, if you have a question about it, you can always send in an e-consult to MAVEN or ask one of the cardiologists or ask me to look at the ECG and let you know what I think. But that sort of thing should save having the patient go somewhere else, especially if it's if it's largely normal. Yeah. It seems like, yes, Ann is pointing out that it seems like machine readings are often variable, and they'll have three different interpretations from three different sheets if the assistant takes several pages. Yes, it can do that, and that may I don't know the explanation for that. You'd think they'd all be exactly the same, but they sometimes are not. And I don't know the explanation for that. unless you've moved an electrode or something like that. One thing about taking an EKG is that I was in the practice of taking a standard 12 lead ECG and then a rhythm strip. Now, if there's normal sinus rhythm at a normal rate on the ECG, you really don't need a rhythm strip. But if there's anything abnormal about the rhythm, it's very helpful to look at a longer tracing than just the one page. Okay. Any other, is there some other question? Uh, you noticed, or maybe you didn't notice. I was going to say, is there any other question? But I changed that to, is there some other question? And I was reading and I think the JAMA, an article about the words we use when we talk to patients. And if you ask, in your patient encounter, is there some question you have for me? That invites a yes answer, and the patient will tell you more than if you say, is there anything you'd like to ask, which implies a no answer, and the patient may not tell you things that are important. An interesting take on interviewing techniques. Okay. Uh, and in that case, I think we can say goodbye. And have we scheduled the number 2 and number 3 of this series? I think we have, but I don't remember.
I don't know offhand, but I'm sure that we have. I'm just putting a couple of reminders in the chat too for everybody. A reminder about the CME survey, and it'll appear in a tab when you close out of this webinar. We really appreciate you taking the few minutes to complete this. Not only does this give you CME credit, but also helps us to plan the best session for you. We share the feedback anonymously with the speakers, and we greatly appreciate your thoughts. So I put that in the chat, and I'm going to put another little reminder in here. About our mentoring program. I just wanted to make sure, let everybody know that MAVEN Project offers mentoring to all of our community providers at any point in your career. Some topic ideas to reference: new to practice providers, challenging case review, preventing burnout, building teams, and executive coaching. Also, we offer specialty specific mentoring like EKG or CGM or reference the topic of today's session. And the survey will pop up after you leave this webinar. For the person that just had that question in the chat, I don't have a link to the survey.
Okay,
Let me just make sure.
okay, so I'm going to sign off.
Okay, thank you so much, Dr. Schulman. Thank you, everybody, for attending. Hope everybody has a great rest of your day.
Nice to see you all.
All right, bye.